We now move to the second part of the presentation titled A Never Before Opportunity to Strengthen Investment and Action on Adolescent Contraception, and what we must do to make full use of it. In the first part, we addressed what is this never before opportunity, why is it that adolescents are unable to obtain and use contraception, and what do we need to do differently to ensure that adolescents can use condoms and other contraceptives correctly and consistently. In this part, we want to focus on what needs to happen at the country level. What do we want to see happen in countries? The first thing is we want national laws and policies that enable health workers to provide contraceptive services to adolescents without restriction, and which go one step further, which actually require them to provide contraceptive services to adolescents. We've done an analysis of the existing laws, policies, and strategies in a number of countries: South Africa, Paraguay, Philippines. Other organizations like the Population Reference Bureau have done similar analysis. And what we find is that while some countries have enabling policies, there are many that are restrictive. In many parts of the world, still unmarried adolescents or adolescents below a particular age cannot obtain contraceptives at all or without parental or spousal consent. We need sound enabling policies, but enabling policies to be translated into action need to be translated into strategies. Strategies that contain evidence-based interventions with clear job descriptions in terms of who does what and budgets to deliver these interventions. We also need indicators to track progress that are disaggregated by age, sex, and socioeconomic status. In this slide, we present the investment case, the reproductive, maternal, newborn, child, and adolescent health investment case for Liberia. And Liberia has a strategy which meets all the requirements described in this slide. We need policies that are evidence-based, respond to local needs, require health workers to provide contraception. We need strategies to translate these policies into action. But most importantly, we need implementation, rigorous implementation, so that strategies are translated into action and benefit adolescents. Implementation with functional systems to translate them into action. Implementation with the involvement of civil society, including networks of youth organizations and young people. Two examples. Mozambique is a country which has put in place a program called Geração Bis, in Portuguese, a busy generation. A program which involved ministries of health, ministries of youth and sport, and ministries of education. A tripartite arrangement to deliver 3 complementary interventions with coordinating committees at the national, provincial, and district level, with young people and youth organizations involved at all 3 levels. This kind of functional system meant that implementation, complementary implementation, was possible. Another example is the Udan program in the Jharkhand state of India, a program which scaled up sexuality education statewide over a number of years, and based on the success of that, moved from older adolescents to younger ones. One of the keys to this success was the involvement of an organization called Center for Catalyzing Change, which worked in partnership with the government to deliver the program, to support the delivery of the program by government functionaries in government schools. So implementation is extremely important. The third thing is we need program reviews. We need implementation with monitoring to check how implementation is taking place, but periodically we need to step back and find out how implementation has gone. We documented England's hugely successful teenage pregnancy strategy. which contributed to over a 50% reduction in teenage pregnancy in England over a 10-year period. What happened in England was 5 years into the strategy, when the government found out that progress was limited and uneven, as you can see in the slide, the plateauing of the graph, the government did a mid-strategy review. They identified 3 districts where progress was good and 3 that were not good, matched for socio-economic factors, and looked at why progress was good in some places and less good in others. And they identified that one of the important issues in areas where there was lack of progress or limited progress or patchy progress was the implementation was uneven, cherry-picked interventions, some interventions at the expense of others. So they used these findings to move to the next phase of implementation with a no democracy approach and saying, if you want funding, you need to do the entire package of interventions and do them as required in standard operating procedures. Midterm reviews like these are extremely important. And finally, we need research. We need implementation research to answer context-specific challenges in programs. In this slide, we show a number of programmatic barriers that a 10-year program led by a group of Dutch organizations found in implementing sexuality education. Barriers at the community level, barriers at the school level, barriers at the teacher level, and barriers at the student level. And these need to be addressed, understood, and addressed through research to find out how they could be overcome. So we need implementation research to identify and answer the programmatic challenges. And what we also need to do alongside this is to learn from the lessons being learned on the ground. We need to learn from the huge successes that some countries are achieving. Not only because we can learn useful lessons from them, but we can communicate the message to the wider world that this is possible to do. This is possible to do and is achieving useful results. Finally, we need sound data. Data is crucial to shape and reshape our efforts. Data on the rates and outcomes of adolescent pregnancies, data on contraceptive use, as I showed you in relation to Tanzania, data on how policies and programs are functioning, and data on what is the effect of all this on adolescent sexuality, on adolescent knowledge, on understanding about sexuality, on adolescent practice. Data is the basis, the foundation on which good programs can be formulated and then shaped and reshaped as we move forward.
There are a small but growing number of countries that are moving forward with adolescent contraception. Ethiopia is one case in point. About 30 years ago, a widespread famine affected Ethiopia, and the overall condition of the country was fraught with civil war, famine, and deaths on an unimaginable scale. However, now Ethiopia has transformed. One example of this is the Health Extension Worker Program. Over 35,000 health extension workers, these were young women workforce. They've been trained since 2005. This was a national population-based program, however, targeting all women. But since adolescents do make up a large majority of married women, they benefited greatly from this program, which essentially distributed contraceptives on a population-based scale. And we see that Ethiopia has made major gains in contraceptive use among young married women. You can see this in the following slide. DHS data from 2014 and 2016 show that these results continue to be demonstrated. In addition to contraceptive uptake, there's also been reductions in child marriage and female genital mutilation in Ethiopia as well.
The Ethiopia example is an outstanding one. It's an inspirational one. It demonstrates that you can move from a basket case situation to a global model situation with good leadership and good management. And Ethiopia is only one of a small number of countries making this transition in adolescent health. That brings us to the end of this presentation. We'd like to conclude with 4 key messages. 1. We have a never-before opportunity to address adolescent health, an opportunity that was not there during the Millennium Development Goals era, an opportunity that is there in the Sustainable Development Goals era, an opportunity to address adolescent health, and in the context of this presentation, adolescent contraception.
The second is that we currently have a much better sense of what needs to be done to meet the needs of adolescents and to enable them to realize their rights and exert agency over their sexual and reproductive decisions.
The third key message is that we have learnt a number of useful lessons in delivering contraception, in increasing the use of contraception in small-scale, time-limited projects. The big questions now relate to how we can take this and apply this at scale and learn the lessons from the scaling up process. Scaling up with quality and scaling up with equity.
Last key message is some countries are already moving forward, such as the example of Ethiopia. So we need to recognize and celebrate these successes, share them widely, and use these lessons learned in moving forward.
So that brings us to the end of this presentation. Grateful thanks from Pooja and myself. Grateful thanks from WHO. We hope you found this presentation interesting and relevant to your work, to your needs. We hope that you find it interesting enough to reach out and access the paper on which it is based. The paper is available open access in the Reproductive Health Journal. And do feel free to contact us if you require any additional information or clarification. Thank you.